I wish to be provocative but not antagonistic. For all intents and purposes, our paths will cross only once in my lifetime, and so I want to make an impression upon you on the way we treat diabetes and cardiovascular disease. I know that we are all cardiologists, and very few of us actually prescribe cardiovascular diabetes medications, but I hope to change your mind about doing that this afternoon. We know that diabetes is a tremendous risk factor for cardiovascular death. Why am I, as a cardiologist, talking to you about type 2 diabetes? What do diabetic patients die of? 80% of them will die of a heart attack or a stroke. If a person in the United States comes into the ICU with their heart attack, 2/3 of them have prediabetes or diabetes. If you follow the third that does not for 5 years, they now are pre-diabetic and diabetic. So 85% of people with heart attacks and strokes are pre-diabetic or diabetic. Diabetes, depending on who you read, raises your risk of a cardiovascular event by 2 to 8-fold compared to the general population. What is the death rate over 10 years for type 2 diabetes? 50%. Half of the people you see within 10 years with diabetes will be in the cemetery. So for every one that you treat, there's already one in the cemetery. Not very many physicians, I believe, understand the lethality of type 2 diabetes. If you have it, you have a 50-50 chance that you will not be here in a decade. If you have prediabetes, what is your death rate in 10 years? It's 30%. Is that an acceptable mortality rate for any disease process? These are people with prediabetes. In the United States, only 0.8% of people with prediabetes will see a medication for the treatment of sugar. Let's talk about the LEADER trial with liraglutide in type 2 diabetes. 9,340 patients followed for an average of 3.8 years. All of them have cardiovascular disease and type 2 diabetes. So a population enriched for cardiovascular death. So we want to perform an intervention that helps reduce this risk of a heart attack or a stroke or a fatal event. You can see the baseline characteristics. They are elderly, obese. They are on the standard of care. They are all treated with ACEs, ARBs, statins, aspirin, angioplasty for STEMIs, et cetera, and liraglutide is given instead of placebo. And what did they find? They found a 22% reduction in cardiovascular death over the follow-up of this trial. The max amount of time follow-up was 60 months. You can see that the curves continue to diverge over time, so that theoretically, the longer you are on liraglutide or Victoza, the greater the benefit for your cardiovascular patient. As a cardiologist, do you think this is something that you should consider for the treatment of your patient? Should you say, I'm not going to treat diabetes, it is not my field, I'm going to refer this to the primary care physician, I'm going to refer this to the endocrinologist, I'm going to ignore that this medication reduces my patient's death rate by 1/5. This is inadequate. A cardiologist is there to prevent cardiovascular death. Why would you not consider this as therapy for your patients? I have read that, or I have been told that only 7% of diabetic medications in Israel are for liraglutide. And I am told that only 3% of cardiologists in Israel have written liraglutide and or a diabetes medication. In the United States, there are 30,000 cardiologists. 6,000 of them have written a diabetes drug, probably Jardiance. Only 3,000 of them have written for an injectable, probably Victoza or liraglutide. So, very few, only 1,000 cardiologists. So less than 3% of US cardiologists prescribe this medication. So I'm not criticizing in Israel, I'm also noting it in the United States. This is the reduction in the primary endpoint, 26% for reduction in death, heart attack, and, 15% reduction in death, heart attack, and stroke for liraglutide. I think that's all I have to say about the trial. Do you need to know the mechanism of action? No, you don't. These are cardiovascular endpoint trials. They are not mechanistic trials. Now that we have the result, now we start looking for the mechanism. I can tell you that the mechanism is not related to reduction in hemoglobin A1C. It's not related to reduction in fasting blood sugar. It's not related to reduction in weight. It's not related to reduction in blood pressure. The pharmaceutical companies got these drugs wrong. GLP-1 agonists and SGLT2 inhibitors are not treatments for diabetes. They are treatments to reduce cardiovascular death in diabetes that just so happen to lower blood sugar, that just so happen to lower body weight, blood pressure, A1C. As a cardiologist, I could care less what their fasting blood sugar or their A1C or their weight is. I could care less. I just don't want them to have a heart attack or a stroke or cardiovascular death. This is the way these medications should be viewed as, cardiovascular medications. Well, this is all-cause death. And compared to placebo, there were no safety concerns. There are, in the United States, of course, there is a high risk of medical malpractice. Of course, so they practice defensive medicine in the United States. I'm not going to say I do not. I do. There are two types of medical errors. There are errors of omission and errors of commission. Of course, we get sued for errors of commission. I left the knife inside the patient on surgery or something like that. I cut off the wrong leg. But there are much more errors of omission for which you will never be sued. You as a cardiologist will never write them Victoza, and they will die a cardiovascular death. The informed patient would say, I need to sue that doctor because they did not give me liraglutide to prevent my death. But it's an error of omission. It will never be noted. We are all guilty of errors of omission in the medical treatment of our patients. Now, at this point in time, I want to do a comparison. If liraglutide is written for only 7% of diabetic prescriptions in Israel, 75% of prescriptions are written for metformin. And probably everybody in this room thinks that metformin reduces cardiovascular events. The devil is in the details. I want to do a comparison with the LEADER trial and the UK PDS trial. The UK PDS trial was initiated by Dr. Robert Turner back in the 70s. It was initiated in 1977 and published in 1998. The goal of the trial was two things. Does intensive control of sugar reduce cardiovascular events in diabetes? And which medication does that? Well, back in 1977, they had only metformin, sulfonylureas, and insulin. So Dr. Turner, as they did since 2008 in this century, said, let's design a cardiovascular outcome trial, placebo, metformin, insulin, sulfonylurea, randomized blinded groups, and follow them for a minimum of 10 years and see who was alive after a decade. I will not waste your time on insulin and sulfonylurea. They are worthless medications for reducing death, heart attack, and stroke. As a matter of fact, there is a signal that sulfonylureas increase the risk of cardiovascular death. In the prescribing information for every sulfonylurea in the United States, in the hazards and precautions box, it says may increase the risk of cardiovascular death. It is the only class of diabetes medications that has this warning. I am talking to you about a medication that has the indication reduces, not may reduces the risk of cardiovascular death. So, the UK PDS trial, 342 patients on metformin followed for up to 20 years. How many patients in the LEADER trial? 9,340. How many heart attacks and deaths in the UK PDS trial? 50 deaths, 39 heart attacks for metformin. How many deaths in the LEADER trial? 828. How many heart attacks? 631. When did this supposed benefit of metformin, which when you read the trial, there was a 39% reduction in myocardial infarction and a 36% reduction in death? Where did they get when did this benefit start to show? About 10 to 15 years after the initiation of metformin. When did the benefit for liraglutide begin to show in the LEADER trial? About a year. Now, what was the placebo group in the LEADER trial? 70 to 90% of patients are on aspirin, statins, ACEs, ARBs, angioplasty, bypass surgery are available to us for the treatment of our patients, standard of care in the 21st century. What was the placebo group in the UK PDS trial in 1977? 1.5% on aspirin, 0.4% on a lipid-lowering drug. Now, in 1977, that 0.4% of physicians who prescribed lipid-lowering therapy, that is a great doctor in 1977. Also the one that prescribed aspirin for a diabetic patient in 1977. That is a great doctor, way ahead of their time. 16% of patients on hypertensive medications. ACEs or ARBs? No. Captopril was not released until 1991. Losartan was not released until 2010. Lovastatin was not released until 1987. The medicines did not exist at the initiation of this trial. What was the goal in the placebo group? To keep their fasting blood sugar less than 270 milligrams per deciliter. What was the average LDL cholesterol in the placebo group in UK PDS? 146 milligrams per deciliter. When today we know the most aggressive guidelines for diabetes patients with cardiovascular disease is an LDL less than 55. And if you look at the Fourier and the Odyssey data, and we should be treating our patients to an LDL less than 20, not 55. What did they tell these patients in the placebo group since they had nothing to treat them with? Eat a low-fat diet. We know that is worthless. If you eat a low-fat diet, what do you eat? You eat a high-carb diet. So you treat your type 2 diabetic patient with a high-carb diet and nothing else. This is the comparison group to metformin. A mediocre number of patients, a mediocre number of events compared to nothing. Do I think metformin reduces death, heart attack, and stroke? Of course I don't. Yet 75% of people get this drug, and only 7% in Israel get liraglutide. It is illogical. Perhaps one of these days we will not recommend metformin as first-line therapy because it's a worthless drug. Do you think that metformin in the 21st century, if I gave a statin and reduced that LDL cholesterol from 146 to 91 like it was in the LEADER trial, do you think that would abrogate the supposed benefit of metformin? Of course it would. All I can tell you from the analysis of the UK PDS data, which I believe belongs in the Smithsonian as just historical interest, I can say that metformin is possibly better than nothing. Possibly. Whereas I know that liraglutide is of tremendous benefit. Now, that's liraglutide in the LEADER trial. Let me tell you about something even better. Semaglutide or Ozempic for the treatment of type 2 diabetes and cardiovascular disease. 3,200 patients treated for an average of 2.1 years. Here is the reduction in the primary outcome, not a 13% reduction like liraglutide for the primary endpoint reduction. It is a 26% reduction. Not a 14% reduction as in the leader trial, a 26% reduction in non-fatal MI. Not a 14% reduction in non-fatal stroke, a 39% reduction. Just over 2.1 years, not 3.8 years. This drug is now available to you here in Israel. If I had a loved one, a parent or a child with type 2 diabetes and cardiovascular disease, would I give them metformin? No, I wouldn't, because I probably like them. I would give them a GLP-1 agonist where the data says liraglutide and semaglutide, Victoza, and Ozempic should be your drugs of choice. But because it's an injectable, because you have to combine it maybe with patients on insulin, in the leader trial, 40% of patients, 43% of patients were on insulin. 50% of patients were on that ridiculous medication sulfonylureas, and 75% of patients are on metformin. What's the next most common prescribed drug besides those top three? DPP-4 inhibitors, another worthless class of medications. 0% reduction in death, heart attack, and stroke. And that is a branded name that costs money, not even generic. And it's just as worthless as drinking a glass of water for your type 2 diabetes. Thank you.
If you can stay, Dr. Miranda, if you can stay there. Can you stay there, please? Any question? I have a question for you in the meanwhile. Is there any data supporting treating patients with cardiovascular disease with Victoza if they don't have diabetes or they have diabetes with normal hemoglobin 1C?
Primary prevention?
Yeah.
No. So in the leader trial, the two clinical parameters that told us who will get the greatest benefit from liraglutide were they had cardiovascular disease or they had chronic kidney disease. Those are the two clinical parameters.
Is it chronic? So let's say that we have a patient with STEMI. We did the angio. There is a 3-vessel disease. We put a stent in all of these 3-vessel, and he's diabetic. He's not treated. He's not treated. The hemoglobin 1C is 7.1. So will you give him Victoza in the hospital?
Absolutely. Absolutely. Remember, these are patients, they were enrolled a minimum of 2 weeks after an acute coronary syndrome or a cardiovascular event. Less than 2 weeks, you were excluded from the trial. So relatively soon after a cardiovascular event, you can give the drug if you wish. And you will, within a year, reduce their risk of a cardiovascular event. The curves will start to diverge. So the quicker you start it, the quicker the clock starts ticking on them dying, not dying.
So why not starting the Victoza before the primary angioplasty? Like,
I agree with you, sir. So if 80% of type 2 diabetics eventually die of heart attack or stroke, that to me is a cardiovascular equivalent. As far as I'm concerned, even though it is not on U.S. indications, every diabetic patient, primary or secondary, should get it. Now, let me even go a little bit further. Why is a fasting sugar of 126 and an A1C of 6.5% our cut point for the diagnosis of diabetes? Because back in 1991, a quarter century ago, that's when you could see diabetic retinopathy. Fair enough. I completely agree with that logic. But in 2019, with today's retinal scans, retinal photographs, computer algorithms, computer readings of the scans, et cetera, at what levels can we see diabetic retinopathy today in 2019? A fasting sugar of 102 and an A1C of 5.5%. So, as far as I'm concerned, prediabetes is diabetes. 30% death rate over 10 years. Very close to the 50% death rate over 10 years for type 2 diabetes. If you take a pre-diabetic patient and do an oral glucose tolerance test on them, 30% of them will now fulfill the criteria of diabetes. 20 to 25% of people with prediabetes have microvascular disease, retinopathy, nephropathy, neuropathy. Prediabetes is diabetes. 50% of the U.S. population has prediabetes. 14% of the population has diabetes, a remarkable underestimation, because 30 to 40% of diabetics in the United States are never diagnosed or undiagnosed. So prediabetes is just as lethal. So the reason I said this is because would I use liraglutide in prediabetes? Absolutely. I do it every day. Every day. Now, the American Diabetes Association guidelines and the AACE guidelines do recommend the consideration of liraglutide for the prevention of diabetes in pre-diabetic patients. They don't say for reduction of cardiovascular events. But it is in the guidelines that you can use liraglutide for prediabetes. So why can't you use liraglutide for type 2 diabetes without cardiovascular disease? Known cardiovascular disease, because they all have cardiovascular disease.
From the audience? If not, let me just ask another question. Is there a patient with coronary disease that you will prefer the Jardins as a risk reduction than the Victoza?
No, they are complementary medications. So basically, the benefit of Jardiance or empagliflozin or Invokana canagliflozin begins 59 days after you start the medication. What other medication do you start for your patients and the reduction in death starts less than 2 months later? No drug. No drug. So it's a hemodynamic mechanism, whereas the benefit of liraglutide and semaglutide begins after a year of administration. So it's an anti-atherosclerotic benefit. So they are complementary medications with different mechanisms of action that should, as far as I'm concerned, always be used together.
Do you?
I understand those diabetic patients, whether typical diabetes, overweight, and so on. Would you characterize patients who develop a little bit of high sugar or pre-diabetes because of statins? Will you treat them aggressively with the same aggression?
All right, so the devil again is in the details. When you look at statin-induced diabetes, when you look at the data, what does the data really show you? You need to treat 255 patients with a statin to get 1 additional case of type 2 diabetes over 5.1 years of follow-up. Out of those same 255 people over that same 5.1 years will have prevented 10 deaths, heart attacks, or strokes. When you look at the data with statins, they converted, if they accelerated diabetes, it was a patient with prediabetes, and they only accelerated their diagnoses to diabetes by 6 weeks. It is a clinically trivial concern. It should not even be considered. Any other questions?
Any question? Yes, please.
In cases of diabetic patients with concomitant heart disease, have you any comparative head-to-head data regarding the cardiovascular outcome if using GLP-1 agonist versus GL2 inhibitors like empagliflozin?
There is no comparisons between those two classes of drugs. There is plenty of data of complementary concurrent use, but not head-to-head comparison.
Thank you.
Okay, just one last question for me, maybe. Concerning the doses, actually most of my patients with Victoza are failed because of side effect. You have a specific recommendation how to decrease this side effect?
Warn them. So I tell all of my patients, so if a patient comes in de novo and I happen to be fortunate enough to initiate their medications, I'll give you a little scenario. I give them metformin, not to reduce death, heart attack, or stroke, but because it synergistically acts with the GLP-1 agonist to help lower their weight dramatically, and an SGLT2 inhibitor. So I give them all 3 drugs. So of course they're going to get a gastrointestinal side effect. And I titrate them up on their Victoza, slowly. You don't have to do it over 3 weeks. You can do it over 6 weeks if you want. You can do it over 12 weeks if the patient is particularly GI sensitive. That's not a problem. That would minimize the discontinuation of Victoza. The discontinuation rate of Victoza in the LEADER trial was only 9.5%. So over 90% of patients tolerated Victoza, and the average dose was 1.78 milligrams. So they tolerated the full dose. So it is uncommon. But what I tell my patients is, let's say that you start them on metformin alone, because most physicians are trained to start stepped care therapy. Start metformin first, maximize the dose. If that fails, then go to your next drug. If that fails, then go to your next drug. This is a recipe for failure. So you put them on metformin, and most people start them on a low dose of 500 milligrams twice a day, which has a minimum physiologic effect, unless you are a slender Japanese female, and they get a side effect. The majority of patients on metformin get a GI side effect. Well, I got an upset stomach, I have loose stools, I have diarrhea. I feel bad on this drug, I'm not taking it. But I give them triple therapy, and they're probably going to have even more side effects than just metformin monotherapy, but they lose 30 to 70 pounds on triple therapy. The person that says that, well, gee, I'm a little bit upset stomach, but I've lost 30 pounds. I'm going to keep taking this drug.
Is there any study that examines the combination of GLP-1 agonists and SGLT2 inhibitors? The combination, you say you prescribe triple therapy for patients. Is there any study which has done that?
Well, just recently, semaglutide with an SGLT2 inhibitor was published on baseline metformin. Significant weight reduction, A1C reduction, et cetera, not a cardiovascular outcomes trial. Now, I initiate triple therapy, but I always give, if the patient is a candidate, quadruple therapy. Pioglitazone has just as impressive data for cardiovascular event reduction as liraglutide, as empagliflozin, as canagliflozin. The data is just as impressive, and only 4% of diabetes prescriptions in the United States are written for pioglitazone, probably the greatest diabetes medication, in my opinion, ever developed. It is the only direct insulin sensitizer that we have, and insulin resistance is the beginning of your diabetes, and it's the only drug that treats that. So I give quadruple therapy when I can.
Okay, thank you, Dr. Miranda.
You're welcome.